Hey everyone, and welcome to this explainer. Today, we're getting right into the crux of the post-oral surveillance landscape for JAK inhibitors across rheumatology. We've got some really colorful academic graphs, tables, and diagrams lined up, and we're going to use them to build a highly structured look at tolerability for our rheumatology patients. We'll be diving deep into precision prescribing and real-world long-term safety data, taking all those rigorous clinical findings and turning them into actionable insights. So let's just get right to it. Okay, let's dive into this. Here's how we're breaking things down today. First up, the post-oral surveillance era. Then, subtype selection and tolerability. Third, precision prescribing and profiling. Fourth, real-world long-term safety. And finally, our clinical takeaways and what the future holds. So, starting off with Section 1, the post-oral surveillance era, and this major shift toward long-term safety. Look, we all know what happened after oral surveillance. Regulatory and prescribing attention aggressively shifted, right? Suddenly, everyone is zooming in on long-term safety. Major adverse cardiovascular events, malignancies, VTEs, serious infections, the whole shebang. And as we're staring at all this safety data, it brings up this massive, absolutely critical question. Are these observed safety signals uniform across the entire JAK inhibitor class? I mean, do we just treat these drugs as one big, homogeneous bucket when we prescribe? Or does the specific drug and the underlying disease biology actually matter? Well, spoiler alert, the clinical consensus gives us a pretty resounding no. Just take a look at this quote right from our source material. It says, JAK-I is not one drug, with in-class differences in herpes zoster, cytopenia, and infection profile matter for prescribing. That statement right there, it instantly shatters the myth that all JAK inhibitors are therapeutically identical. They are simply not a single homogeneous class. And honestly, treating them like one means we're ignoring some hugely important patient-level safety nuances. Which leads us perfectly into Section 2, subtype selection and tolerability. Time to start deconstructing some of these class-wide myths. Now, what's really interesting about this baseline characteristics table is what happens after patients initiate JAK inhibitors across different conditions, like RA, psoriatic arthritis, and axial spondyloarthritis. If you look closely, adverse event-driven discontinuation was the absolute dominant reason for stopping therapy. It actually wasn't a primary lack of response. In the real world, most patients are reaching a meaningful clinical response way before tolerability or safety concerns force them to pull the plug on the therapy. So what exactly are those tolerability differences that drive people to stop taking them? Well, tofacitinib showed a distinct herpes zoster signal, which pretty much lines up with what we've seen in prior reports. Upadacitinib and baricitinib, on the other hand, brought some more pronounced cytopenia signals to the table. Filgotinib actually showed a generally favorable tolerability profile in some of these subsets, though. To be fair, we have to note that this is within a slightly less mature safety dataset. But here is the absolute most important clinical reality you need to take away from this. Routine glucocorticoid minimization and age-aware drug selection are still your dominant, highest leverage strategies to bring down that serious infection risk across the board. All right, moving on to Section 3, precision prescribing and profiling. Let's talk about the future of biologic selection. And this brilliantly illustrates exactly what we're talking about. This functional phenotyping compares healthy controls directly with targeted therapy-naive RA patients. By literally quantifying phospho-STAT3 signaling ex vivo right after cytokine stimulation, researchers can basically map out a patient's functional cellular phenotype. It's like a biological fingerprint. But why does this biological mapping actually matter in the clinic? Well, it's because of the distinct responses we see here. Patients who had high baseline IL-6 pathway-specific activation tracked with a much stronger clinical response to IL-6 receptor blockers, things like tocilizumab or seralutinib. But conversely, patients who showed a broader STAT3 activation pattern across multiple different cytokine cues, they responded better to JAK inhibitors. The data is incredibly clear here. This kind of functional profiling actively outperforms standard ACPA and CRP clinical predictors. Biology-informed prescribing really belongs in routine care now, not just locked away in a research lab. Let's jump into Section 4, real-world long-term safety. It's time to examine the hard data. Take a look at this force plot. It breaks down long-term safety outcomes, specifically comparing baricitinib against TNF inhibitors in rheumatoid arthritis patients. But here's the kicker. These patients were explicitly selected for their high venous thromboembolism, or VTE, risk profile. By looking at these hazard ratios, which cover VTE, MACE, malignancies, and serious infections, we get some incredibly crucial real-world reassurance. This data directly refines where we position baricitinib post-oral surveillance, especially when you're sitting down having those tough conversations with VTE risk-selected RA patients. It takes us out of theoretical fear and grounds us in hard comparative data. 4.8 years. I really want that number to sink in for a second. That is the median follow-up time we got from the integrated data of 7 different clinical trials for the JAK1 selective inhibitor, filgotinib. When we are debating long-term safety, this is exactly the kind of robust, multi-year timeframe we actually need to confidently evaluate a drug's profile. So, following that massive 4.8-year median follow-up, let's look at the exposure-adjusted incidence rates, specifically for MACE and VTE. You can see the rates detailed clearly here. And honestly, what they reveal is that the absence of compounding long-term safety signals provides a ton of reassurance. This integrated 4.8-year safety profile strongly supports filgotinib's ongoing positioning as a confident JAK1 selective oral option for RA management. Bringing us to our final segment, Section 5, Clinical Takeaways and Future. Let's talk about navigating these treatment strategies. So the crucial point is how we navigate this incredibly common clinical debate. JAK inhibitor monotherapy versus methotrexate combination therapy. It's a tough balance, right? On one side, JAK monotherapy simplifies treatment regimens immensely, and it's a direct, effective solution for your MTX-intolerant population. On the flip side, combining a JAK with MTX absolutely maximizes your overall efficacy potential. But it comes at the cost of an increased pill burden and elevated tolerability concerns for the patient. And this whole debate is anchored perfectly by this quote from our sources: JAK monotherapy versus MTX combination in RA, the choice matters and deserves evidence beyond habit. That really hits the nail on the head. We just can't rely on historical prescribing habits anymore. The comparative effectiveness data we've explored today essentially demands that our treatment strategy choices be rooted in evidence-based, shared decision-making that is specifically tailored to the individual patient's context and comorbidity profile. I want to leave you with a provocative thought that really sums up the massive paradigm shift we are witnessing right now. With whole blood functional profiling moving out of the lab and into routine care, guiding us toward cluster medicine based on shared molecular pathways, will empirical, trial-and-error biologic cycling soon be a complete relic of the past in rheumatology? The evidence strongly suggests that the future of precision rheumatology isn't years away, it's already here, and it's ready to transform patient care. Thank you so much for joining me on this explainer, and as always, keep questioning the data.